The case, I understand it, is duodenal polyp referred for evaluation prior to potential resection. So this will be a nice discussion we can have. This patient is how old?
It's a 78-year-old patient, quite comorbid, who was indeed referred to us for a circumferential lesion in the third part of the duodenum, and it's been biopsied as being tubulovilous with low-grade tubulovilous adenoma with low-grade dysplasia.
So take us through, gentlemen, how you would assess this lesion and what you think the management should be. And start, please, if you would, start from your first impression of this lesion.
So my first blink impression.
Wait a minute. A blink impression is that we need to have a still image to make it with the whole lesion in the image.
A bit back. We need a bit more of an overview. It's a challenging position. It's quite far in D3.
I'll start with that. Okay, have a look. Pause it there. Okay. What do you think, Tomasz? What are you feeling?
My feelings are... what I think is that, yes, we are in D3. I see a lesion that is at least covering from here at least a half, or rather I would say at least 3/4 of the circumferential diameter. The lesion is not homogeneous on the height, I mean. So if this would be in the colon, I would or here also, according to Paris classification, the morphology, I would say it's a 2A1S. So there are flat parts and there are protruding parts. That's the surface pattern. And so from afar, I would say that, as well as I would say that on the 6 o'clock, there is a characteristic whitish area that if I would just see that small lesion, what now is white, it will be completely consistent with a duodenal small adenoma. So yes, this is an advanced adenoma. Thing is that before GAMP, I haven't used caps.
It does take some procedures to get used to the capping. That's true.
Yeah.
I think it's in D2.
This is the interesting discussion. Let's so David's saying maybe it's in D2. So of course then that's for me even more risky. I think someone's been a little swayed by the endoscopy report potentially, because I think it was Tomasz, did you say that it was in D3 or did you not say anything? I know Xander said it was in D3.
I definitely said, because that was my impression and that corresponded also what I have heard before I started the procedure.
It's also written like that in the endoscopy report of the referral doctor.
That should be not anything compared with your personal impression. I'd like everyone in the room to form their impression of whether they think it's D2 or D3.
For me, it's a D2.
I said form your impression.
What am I? Can I just?
But don't tell him, because I want you to tell him later.
Sorry.
No, you don't apologize. It's too funny. Right. So this will be the third attempt. Let's either do it this time, or I'll come and see if I can have a look and see if I can see it. Because, yeah, if we are thinking, I mean, it is my gut feeling. I have to say that this is not involving the major papilla, but I want to know that, right? I want to see it for myself before we go anywhere near anything like this. Yeah. And of course, you could put down a side view endoscope if you're still struggling to find the papilla. No issue with that. But right now, we're not going to do that. Ian's making a noise like it's already passed. Okay, why don't you switch to the pediatric colonoscope for a second and do that part, and then if you can't see it with that, then I'll come at the end and make sure that we see the papilla. But at least we'll then get some examination of the polyp. Just while they're doing that change,
David, has the patient had any imaging? For a lesion like that, should be easily visible on the CT.
Has the patient had cross-section imaging? Don't know. Sander will hopefully have a look.
Yeah,
I wouldn't necessarily say, well, we haven't seen it properly yet, but I mean, yeah, I think it's an important point. Okay. While we're waiting for that, what are your opinions that you're forming, Sophia? So now you can tell it out loud. Your opinion of that polyp. Yeah. Like sort of cancer, no cancer.
Blink impression is cancer.
Your blink impression is cancer, okay. And therefore resection by, nothing is an option because of the patient's age. But say you think it's cancer, what sort of thing do you think is going to have to happen then to resect that?
When I saw the polyp, I thought immediately to surgery.
Okay, but that's actually very honest and very important. I didn't, and I think that's maybe a difference between me and you. But I think that is a sort of thing that the vast majority of people would think. David, do you agree with that? When they see that sort of thing, they think there is no hope for that. Maybe we get to talk to the patient. Maybe the patient's too comorbid. Maybe we do nothing, or this is not for endoscopy.
Yeah, but I think to me, it looks like something that is potentially resectable by someone that's experienced in doing this kind of lesion.
Yeah, well, I would fully agree with that. I think it looks resectable to me right now, but I'm interested in Sophia's point of view because the difference between you and David is, of course, a lot of experience, and that David is also working in a bit in the interventional space and in a centre where they're doing that sort of thing. So, yeah, but I do think your voice is the voice of the majority of people, actually. So I think that hopefully people can, the first takeaway from this is don't see that and immediately think it's for surgery. So thank you for making that point. Michele, what's your opinion?
My first impression that the lesion was not a cancer, but as Tamas said, I would like to see also the back of the lesion and
get more information. Yeah. So I think we all want more information, which is important. I think that what has been demonstrated so far is some areas of different morphology, and as Tamas said, a very large, bulky component, which, and I think he made an excellent comment, as he often does, that are we ever going to know, even if the entire surface pattern is normal, if under that there is something or not? That speaks a bit to Roland's point, I think, about scan. I think that's necessarily the wrong thing to do. We can turn off the artificial intelligence. It's not going to help us much in this situation. It's turned on because we put a colonoscope on, of course. It doesn't turn on with a gastroscope. But if you're using a colonoscope where it should not go, or onto Olympus, then it turns on.
You're calling polyp now, that's strange.
Well, but it will be, it's not trained on this, so it almost certainly will recognize the duodenal polyp.
Do we know what comorbidity the patient has? Because they did say at the beginning that she's a comorbid 78-year-old.
So she has a breast cancer. She's been worked up for a goiter or maybe a thyroid carcinoma, so that's still in workup. and she recently had a pacemaker put in for a sick sinus syndrome. So, and she is very immobile, so she came with a wheelchair. So she's dependent on care of others. And she's taken also anticoagulants for, yeah.
Did say that before. Okay, and is there any value, do we think, in the seminar room? Do we ever think there's of any value of taking biopsies here?
That kind of big lesion, if you don't see anything in particular, I don't think so, actually.
Okay, anyone think that there is a value of taking biopsies? Now?
We have sampling bias and it looks benign, so no.
Is that a normal papilla, do we think? I'm hearing a whispered yes.
Yes.
Hearing some more yeses. Where would the minor be now? Up in here somewhere. Okay, I think we should leave this poor lady alone a little bit more. Okay, well, this was very informative. Let's go and discuss the pros and cons. Maybe we can get the video already made. Sander, maybe you can just finish the gastrocolonoscopy. So we should capture this conversation. So I walk into the room and there's a conversation going on about, should we, shouldn't we? I mean, what are the views of people in the room about that? So we know the patient history, right? Breast cancer stage was not defined. Important to define that, I think. Very important. On anti-co for some decompensated heart problem, et cetera, in a wheelchair, 78 years old. Okay, so that's about the patient history. Yeah, let's go around the room. I mean, first of all, let's start by a show of hands. Who would resect that? Right, well, that's a better question. Who would try to convince the patient that maybe resection was not an optimal solution to this problem?
Yeah, there are more risks than a benefit.
Right, that's what I mean.
I don't know. I think that I will just discuss with the patient, explaining to him the risk, the benefits. It's hard here because when I look at your consultation, you're saying to the patient numbers, percentages of risk, and this kind of stuff. I think that here is very, very hard, and you need a lot of experience to explain to the patient which are the risks, because this is pretty rare at the end. This is also.
Yeah, I mean, maybe it's important for us to define a bit some of the risks, right? I think David was just doing that to you as I walked into the room. So why don't you define some of the risks that could be associated with removing this thing? And maybe have the drive so that I can show the thing.
I mean, so I guess, firstly, it would be a reasonably prolonged procedure. So there's the anesthetic risks. But I think one of the biggest risks is going to be bleeding post-resection. I think that's going to be very high and going to be difficult to manage, if anticoagulation is really needed at some point soon after. And, perforation is a risk as well. So I think for me, the real question is, with their comorbidities, is, what is their likely life expectancy? What is their quality of life? And then place that in the context of what's the chance that this becomes malignant in the next 2 or 3 years, versus, because if we leave it, that's the risk that it becomes malignant or it obstructs. But maybe it just sits there like a polyp, and we're risking killing them by doing the procedure.
Yeah, I really think that is the nuts and bolts of it. So what is the risk? And as I always say to patients, right, in my consultation, what is the risk that if we do nothing, that you have a problem? And in this case, and in most situations where I'm seeing patients, it's we have to do something, like there's cancer or something, or at least high-grade dysplasia in the colon. But the first message is high-grade dysplasia in the colon is very much different to high-grade dysplasia in the duodenum. That it's more of a indolent pathology, a duodenal adenoma, or low-grade dysplasia in the duodenum is maybe a better example. So David's point, but my question is, do we know right now, that this is, we took a biopsy that showed low-grade dysplasia? Does that help us at all? In my view, it doesn't at all. So do we know already at the current time, we have a PET scan which shows the lesion, just with a slight issue of interpretation of the position. We have no nodes, no metastatic disease. We have a biopsy that shows low-grade dysplasia. But none of that really helps us, does it? And that's where endoscopic imaging is key. Your ability to interpret these images will probably be the only thing that can inform you as to what you're going to tell the patient, because it's very important that what you tell the patient is going to be, determined by that. If you think this is cancer based on your endoscopic assessment, that is going to change what you say to the patient. I mean, okay, take this patient out of it. Yeah, this patient maybe it doesn't, but in general,
it's an extreme case.
So let's take our endoscopic impression here. And our endoscopic impression here is...
was cancer, but after MBI visualization, I didn't see any irregular path.
Okay, so what you're saying is a complete assessment has changed your view. You initially had a view of cancer. Now it's changed to probably it's just a colon polyp, maybe high-grade dysplasia. I think I would agree with that, David. I think I would agree that this polyp looks relatively homogeneous. I think we can't rule out cancer in this, and I think we need to say that to the patient, but I think we can say right now that this is a laterally spreading lesion of the duodenum. It does not involve the papilla. We therefore know it's at lower risk of having cancer than the type which involves the papilla.
Can I ask something?
And it's relatively regular. Cool, yeah.
Could I ask? Would you take a biopsy? Because sometimes, from my experience, lesions like this, you take a biopsy and the pathologists, they come back to you and they say we found a focus of, and then the whole thing changes what you need to say to the patient after you have the histology back. Because before histology, you might say, as we said, we saw this with MPI and we say it looks like another normal, we might reassure a bit the patient. But sometimes in lesions like this, the histology comes back and increases the concerns. And you have to say a different thing than to the patient.